So it's a huge, huge pleasure to be here in this very historic building and for Hugues to invite us to this really important colloquia. And it's timely because I think many of the concepts we've been discussing today will apply not only to cancer but also outside cancer, and we need to just bear that in mind. So I'm a hematologist, a bit like Laurent, and I've been fortunate to work with some really wonderful people, and hematopoiesis and leukemia has turned out to be a wonderful model to study basic cellular processes. So the question really is, how do you go from a situation where you have a heterogeneous group of cells in the blood factory, the bone marrow, that then somehow become much more uniform and homogeneous and non-functional from a patient's point of view. And so is AML really characterized by differentiation arrest? And we've had a lot of that today. When we're thinking about this question, we must also remember that acute myeloid leukemia, AML, is composed of multiple genetically distinct clones, and therefore, unlike APL, we have, if you will, a model, a disease that is going to be much more akin to the rest of cancer. And indeed, actually, AML is one of the genetically most simple cancers. So when we think about differentiation therapy and loss of self-renewal for other cancers, we must bear in mind that what I'm going to say for AML is going to apply even more for other cancers. We need to understand that if these two phenomena are at play, where are individual clones arrested in the hemopoietic differentiation hierarchy? That's an important question. Does therapy relieve differentiation arrest? Is that really true? And if it relieves differentiation arrest, do you actually also lose self-renewal? So a large part of my talk is really going to follow on from Hugues' talk. They're going to, I hope, be quite complementary. And if differentiation arrest is reimposed, how does that occur at disease relapse? So many of you in the audience will be familiar with hematopoiesis, but maybe not all. So we must remember that each of these compartments is really artificial, that this is a continuum of differentiation. This is not, if you like, boxes with clearly defined rooms. It's, if you like, a really long corridor without any breaks. But operationally, we divide these compartments into a heterogeneous stem cell compartment, and in a human being, there'll be about 100,000 of these cells in our body. There is an early multi-potential progenitor compartment. I won't go through these acronyms, but I just want to point out this cell population, the lymphomyeloid multi-potential progenitor. Again, there are around 10 to the 5 cells in our body that are like that. These then give rise to more mature progenitors, the granulocyte macrophage progenitor, for example, that then gives rise to mature neutrophils and macrophages. And there are many, many, many more mature cells and mature progenitors than these immature cells. All of these are characterized by a cell surface marker, CD34, which I'll refer to, and the mature cells are not. So with that in mind, we showed some years ago, just using a simple marker scheme and using all the cell surface markers that characterize these populations, that 80% of human AML, the blasts, the immature leukemic cells, express CD34, and about 20% don't. And what we showed was that if this is a very simplified cascade of differentiation, that these leukemias here, where CD34 is expressed in most cells, there is a accumulation of tumor propagating cells in immunodeficient mice at a progenitor stage, not at a stem cell stage, but really at a progenitor stage. So if you did RNA sequencing, you could show that the transcriptional profiles of the tumor propagating cells were really most like normal progenitors rather than normal stem cells, though they did have a hybrid signature with some stem cell transcriptional programming. The CD34 negative cells are arrested, really, the tumor propagating cells, really between precursor cells and mature cells, so really very close to the edge of being differentiated. And I was very struck by Laurent Dagos's talk earlier, where, years ago, people had appreciated, 1844, people had appreciated some of these concepts, really. We're just rediscovering them and putting better definition. Okay. So with that in mind, we proposed this model some time ago that though the initiating mutations in pre-leukemia, the mutations like DNMT3A and TET2, may be acquired in long-lived stem cell compartment, the transforming mutations that really take pre-leukemia to leukemia either would occur in an early compartment or they may occur in these later compartments, the LMPP and GMP. And it's really cells that are transcriptionally have a signature most like the LMPP and GMP that form these LSE-like populations. So the LSE concept that Hugues referred to, where a small proportion of the cells were clonogenic, similarly in immunodeficient mice, only a small proportion of cells are tumor propagating. Whether that is true really in a patient, of course, we don't know, because our models, whether they be clonogenic assays or immunodeficient mice, are most likely very inefficient at detecting tumor propagation. But we postulated that the LMPP and GMP-like LSCs were generating the bulk blast population. Now, this is important because the frequency of the LMPP and GMP in normal bone marrow is around 1 in 10 to the 5 or 1 in 10 to the 3. Whereas when a patient presents with LMPP and GMP like AML, the LSC compartment can be 20 to 90% of all the mononuclear cells. So you have a phenomenal expansion of these LMPP-like cells. You could have a 10 to the 7-fold expansion of the LMPP-like cells. Okay, so in addition to this differentiation arrest and maintenance of self-renewal, you have genetic heterogeneity. So we know from a number of studies, and I've just quoted 2, that the number of recurrent so-called tier 1 mutations in a patient varies between very low numbers, so here APL would be down here, all the way to 15 or more. This is almost certainly an underestimate because we're really talking of just tier 1. There will be other genetic variation that we haven't fully appreciated, not only in the coding regions, but in the non-coding regions that will be important for pathogenesis. But suffice it to say, there is a mean of 5 mutations that are currently recognized as being recurrent and pathological in AML, so acquired tumor. And these mutations will be organized in a clonal hierarchy. So here you have an initial cell acquiring a mutation B, and then subsequent mutations being generated in this branch of the hierarchy, and then another branch of the hierarchy here. And we also know that therapy can select different clones, so that if you have a mixed clonal population, therapy A may select out clone AD, whereas a completely different therapy may select out a completely different clone, and then relapse will be clonally quite different. So with these concepts in mind, I want to talk to you about IDH2 mutation AML and the differentiation therapy agent enasidenib that is now in clinical practice. So IDH2 mutant AML constitutes about 15% of AML. There is also an IDH1 mutation, which is seen in AML at about 8%. And these mutations are also seen in other cancers, particularly low-grade glioma and secondary GBM, where 70% of patients will have an IDH1 mutation, so really quite frequent in some cancers. So what I'm about to say may also apply to other cancers. And IDH is a cytoplasmic enzyme. The IDH2 is a mitochondrial enzyme. They catalyze the oxidative decarboxylation of isocitrate to alpha-ketoglutarate. And then the mutant enzymes are gain-of-function enzymes that reduce alpha-ketoglutarate to 2-hydroxyglutarate. Now, the substrates of these enzymes is really the subject of a lot of controversy. And there isn't total clarity about what the substrates are. And different folks will be saying different things, but some of the substrates may include the protein TET2, which Olivier Bernard and the team here in Paris discovered, which is a dioxygenase that is important in DNA demethylation, and they also may be important in providing alpha-ketoglutarate may be a cofactor for the histone demethylases of the that I show here. So the hypothesis is that 2-HG blocks histone demethylases and TET, whereas alpha-ketoglutarate promotes their activity. This is almost certainly too simplistic, but as a first working model, it's something to work with. So the idea then being that mutant IDH generating the oncometabolite 2-HG induces a differentiation block through epigenetic processes. So the company Agios developed a small molecule inhibitor called enasidenib, or AG221, and what they showed was that when they did the crystal structure work, that AG221 binds in the heterodimer, and you do need a heterodimer of wild type and mutant enzyme, and it holds the heterodimer in an open configuration, whereas you really need it in a closed configuration to trigger alpha-ketoglutarate going to 2-hydroxyglutarate. And so with this in mind, the preclinical data that Katie Yen produced in Cancer Discovery was shown here. So if you treat with AG221, these are xenografted mice with primary AML samples, you really got a curative response. Whereas if you were treating with lower doses of AG221, or indeed with a chemotherapeutic agent called cytosine arabinocyte, you got varying degrees of response, and this is vehicle control. But you didn't cure all the animals. So the hope was that this would be a curative treatment. And indeed, this was accompanied in the mice by evidence, morphologic evidence of differentiation. So this then set the scene for the clinical trial that Eitan Stein and Stéphane de Botton here in Paris, and I think patients in Paris may have been some of the first in the world to get access to this drug. They led this study, which was a large study. It started out as a phase 1 study, but then the cohorts expanded into essentially a large single-agent phase 2. And 176 patients were treated. Median age was 67. So you should know that in acute myeloid leukemia, the median age of diagnosis is in the early 70s. And most of our treatments that are curative are really reserved for patients who are much younger, who can tolerate combination chemotherapy and allogeneic stem cell transplant. Older patients, the cure rate's around 2 to 5%. And in the relapsed refractory situation, the median survival is about 3 months, 3 to 4 months. So pretty short. So these were older patients who had at least 2 lines of prior therapy, and the overall response rate was 40%, with a median time to response of about 2 months and a median duration of response of about 8.8 months. These data have been updated recently, and the median duration of response is slightly longer. It's nearer 10 months. Compared to the median survival of 3 months for these patients, this was an improvement. But unlike in the animal studies, we got very few, or if any, cures. And you could see that the duration, so this is months of survival, and this is the probability of survival. If you achieved a really good response called complete remission, you achieved the longest period of survival, but none of these curves really had a plateau, meaning that nobody was really cured. So big difference to the animal model. Impressive single-agent data. Unlike preclinical data, not all patients respond, and the responses are not curative. So why is that? And how does this drug actually work in patients? And I think for us, we came to this really because we were asked to analyze patient samples. And I think the plea I would make to the community is really deeply study the patient samples on clinical trials. And I think the 3 examples that Hugues gave of patients who had resistance to arsenic and showing that the genetic mechanisms there of resistance really prove the mechanisms of action of drug are really, really important. So deep, deep understanding of patient material is really important. And so in patients, the first thing we could show is that with both the IDH140 mutation and the R172, there are just 2 mutations in IDH2 that are acquired, you got suppression of 2-HG. Not in every patient, particularly in the R172 patients, but in most patients, whether they responded or not, the drug was on target. This is a complicated slide, and I'll take you through it slowly. So let's just focus on these top plots here. These are essentially FACS profiles from bone marrow samples of patient before and after treatment. And what we've done here is taken lineage-negative bone marrow mononuclear cells, divided them into a stem and progenitor compartment, a precursor compartment, and a mature compartment. This mirrors the schematic I showed you right at the very beginning. The cell surface markers we use don't really matter, but you can see pre-treatment, most of the cells are in the stem and progenitor compartment, most of them split between CD38 plus and minus, they're LMPP-like, GMP-like. When this patient received drug, you can see a profound change in the profiles. Now you have many more mature cells, you lose that LMPP compartment almost completely, you reduce the GMP compartment. Here is a patient who has precursor AML, where the differentiation arrest was at the precursor stage with some maturation. And you can see that you reduce that precursor compartment quite a lot. This is just quantitated here. These plots are just quantitated. Okay, so we have evidence of differentiation, but we don't know if the cells that are differentiating are really the same cells as we started with. Are we just replacing normal with leukemia? And to look at that, we did the following work. So first of all, the drug restores normal progenitor function. So at complete remission, you see colony formation, but not in patients who are in CR. These are the number of patients studied. This is the most important piece of data. So if you look at the mutant allele fraction of IDH2, how many cells have the mutation? And 50% heterozygous mutation means 100% of the cells are mutant. This is pre-treatment, post-treatment, in granulocytes. You can see there's very little change in the VAF except for one patient. So at complete remission in mature cells, you have mutant cells. This is differentiation therapy. And if you look in vitro at those neutrophils, they phagocytose bacteria and they phagocytose latex beads, and the patients do not get infection. So these mutant neutrophils are functional. Okay, so we then ask the question, if this is a clonal map, so you start off with wild-type cells that then acquire mutations, A, B, and C and D represent mutations. These are ancestral clones. These are terminal clones. What is the clonal origin of complete remission? So unlike APL, where it's more or less a monogenic disease, AML is not a monogenic disease, and it's certainly not a monoclonal disease. So what we showed was that when you treat with, this was published last year, you restore hematopoiesis from wild-type progenitors in a minority of patients. You restore hematopoiesis from ancestral clones in some patients. And in many patients, you'll restore differentiation from terminal mutant clones. So you immediately know this is differentiation therapy without affecting self-renewal. And therefore, it's not curative. And this just shows you a number of patients who we've studied, one who restored wild-type hematopoiesis, one who restored ancestral, and one who restored terminal. How did we show that? Well, this just shows the number of patients achieving molecular remission. This has now been updated, but it's pretty similar. About 1/4 of patients. Now we've looked at about 95 patients. 1/4 of patients achieved molecular remission. And of those, most of them achieve remission with wild-type hematopoiesis. Those patients have the longest survival. Those patients all relapse in the end anyway. So you do restore normal hematopoiesis, but you never get rid of abnormal cells, even in those patients who have molecular remission. And this just shows an example of what we did in these patients. We exome sequence the patient. There are a number of different mutations, and you can see the variant allele frequency at CR. It's not just the IDH mutation you lose most of the other mutations. And then if you look by colony assays, you restore erythroid granulocyte monocyte colonies, you restore normal balance of colonies, and you can show that most of the colonies that are generated are wild type. Occasional colonies just had one of these mutations. Even in these patients, if you look deep enough at the stem cell compartment, you actually will find mutant clones. So you don't totally obliterate self-renewal. However, this is an example of a patient who restored hematopoiesis from an ancestral mutant clone. So we exome sequenced the patient. They had lots of different mutations, including the IDH mutation. The mutations are all given letters here. And then we did single-cell genotyping on this patient. So each column here is a single cell, and we either detect the mutation or not detect the mutation, or the PCR failed. There was a degree of allele dropout, and we had to take that into account. You can see that there are some wild-type cells. There are some cells here which are dark blue, which belong to this clone, which has the SRSF2 and IDH mutation, so forth and so forth. Most of the cells were off the terminal clone. And by doing this kind of analysis, you can derive a clonal structure, a clonal tree, and you can also show that there are some cells where allele dropout may have occurred, and so therefore we put dotted arrows. So this is the clonal structure in this patient at diagnosis. What happens after treatment? After treatment, things change a lot. So if you remember, this is a normal bone marrow. This is the normal stem and progenitor compartment composed of different types of stem and progenitor cells. Here's the LMPP. You can't even see it. Here's the GMP. It's there. This is normal. That's my marrow. This is pre-enasidenib in the patient. Big stem and progenitor compartment, LMPP, GMP, all of the cells belonging to this clone here. You can see that here. At complete remission, you now see mature cells, and the mature cells, most of them come from the yellow clone, some are wild type. So this is where hematopoiesis is coming from. Now, you couldn't have predicted that. There's no way you can predict that a priori. You have to do the experiment. And if you take the colonies, the progenitor colonies, they all come from that yellow clone. So somehow, if you inhibit 2HG, SA, that clone differentiates. Now, the rules behind this are going to take a huge amount of time to work out. And if we're going to start modeling this in mice, this is going to be extraordinarily complicated. How do we generate a mouse that looks like that? I really don't know. So we're going to have to be really quite clever and thoughtful about how we take the next steps. This is a patient, just another example, where you mature from a terminal clone. So again, these are the mutations in the patient. This is the single-cell profile. This is the clonal structure in the patient. It's really quite complicated. And essentially, there's 1, 2, 3, 4, 5, 6, 7 different leukemic clones in this single patient. This is not an unusual patient. This is common. This is what happens. And what happens with treatment? So you now see the LMPP GMP. Most of the cells come from the DIX clone, DNMT3A, IDH, XPO. That's where the tumor-propagating cells are. We've put these cells into immunodeficient mice and shown they are leukemic stem cells. That's where they are. And there are a few mature cells, even before treatment, that come from this clone. Who would have anticipated that having 5 different mutations, you'd still differentiate? At complete remission, the mature cells are a mixture of that clone and that clone. So when you give drug, that DIX clone, the differentiation block is now released. You can make mature cells from that DIX clone. More mature cells come from here, and there are some wild-type cells. But you will see there is a tiny, tiny bit here of the LMPP at complete remission, and that's where that DIX clone remains. You haven't eliminated its self-renewal. What happens at relapse? this is what, I'll go straight to relapse because it's really interesting. At relapse, that DIX clone evolved and acquired 2 mutations. They were probably there right at the outset, but we just couldn't see it. You get a mutation in a transcription factor called DHX15, which is a little bit like ETO. It is a paralog of ETO, and the only other time you get this hotspot mutation in DHX15 is in pediatric AML 821 translocation. And death is another transcription factor never noted before in leukemia to be mutant, and this mutation essentially makes a ETO homolog. So you've recreated an AML1 ETO program to relapse. There's convergent evolution here. So let me just go back to this patient here. These cells that remained were the ones that clonally evolved at relapse. The power of human genetics here, I think, is amazing. Okay, let's just talk a little bit about primary failure of resistance. And here, the issue in the non-resistant patients, most of them had RAS mutations. So this has been seen again and again and again, that RAS mutations are an important mechanism by which you get primary resistance or secondary resistance. And you can see that in those non-resistant cases, they also had a higher co-mutational burden. So these are the number of co-mutations. So it was difficult for us to say it was definitely RAS, but there is something about RAS and a high co-mutational burden. And if you look at the single mutant NRAS patient who had a response, they had a lower co-mutational burden. So there may be some cooperativity here. If you also look at those patients who had a higher co-mutational burden, they're much more likely to have progressive disease, stable disease, or a partial response, as opposed to those who have a co-mutational burden, they're more likely to respond. So co-mutational burden, RAS mutations, less likely to respond to drug, more complex disease. And what about secondary resistance? So these are the patients we've studied, and there are 10 or so patients. And you'll see the multiplicity of different mechanisms that could be operative. These were the mutations that were seen at relapse. So they'd all responded, they'd all had a complete response, and then at relapse, you could acquire an IDH1 mutation. You could acquire mutations in transcription factors. You could acquire mutations in cytokine signaling, so forth and so forth. And this is a gain of an IDH1 mutation. You can see the 2HG rising, blast rising, IDH1 mutation. Because this drug is so specific, it only targets IDH2. This is the gain of a RUNX1 mutation. And then I've shown you this case of clonal evolution. So in all of these cases, you are not eliminating self-renewal. You almost certainly at the outset have additional clones that you can't see. We have 10 to the 13 cells in our bone marrow, don't forget. And every time we do a bone marrow test, we only take 10 to the 7 cells. We're taking a millionth of the bone marrow for sampling. So the fact we don't see something at diagnosis, well, doesn't mean it wasn't there. So I'd like to just stop by saying that these kinds of patient studies establish a mechanism of action in patients, confirming what was seen in animal models. We showed that co-mutational burden and RAS pathway mutations at diagnosis correlate with primary resistance, setting up the concepts of combination trials with MEK inhibitors. And secondary resistance arises from clonal selection, most likely not because the drug doesn't eliminate tumor-propagating leukemic stem cells. So we need to think about how to do that. I just want to set out, I'm going backwards, the people who helped, and in particular I want to acknowledge our collaborators in Paris. Virginie's in the audience. She and her group were absolutely instrumental in delivering this, together with Olivier and Stéphane, and Muriel helped Lynn, who did the work. We also worked with Memorial Sloan Kettering and with drug companies to deliver this. And I think what I like about this work is that I think we should be doing this in all our clinical trials. I'll stop there.